Good afternoon, doctors. Thank you for joining this webinar, How I Do It, Pediatric Neurosurgery by Masters. This is episode 4, brought to you by Park Clinic and Indian Society of Pediatric Neurosurgery. This is an initiative, a digital initiative by Health and You, which is a joint venture with Newlink Company Limited, Japan. Our mission is to fulfill unmet medical needs by launching innovative first time in India products. Like we have Amnuride, Amitriptyline plus Mecobalamin put together, Amnuride 5, 10 and 25 for neuropathic pain and for migraine. We have Amnuride Beta when migraine is not controlled by one drug. One can combine propranolol. So Amnuride Beta comes with 520 ER and 1040 ER. Amitriptyline 5 mg, 10 mg with propranolol 20 and 40 mg extended release. We have first pharmacological combination for neuropathic pain, Amnuride P, where pregabalin is made into sustained release form to match pharmacokinetic profile of amitriptyline so that your patient can get 24 hours of pain relief. We import Mecobalamin injection from Japan to give you the highest quality Neurite injection in neuropathic pain. We have launched first time in India 2.5 milligram strength of clobazam specifically for pediatric neurology patient, epilepsy patients. So now you can add flexibility, add control with Adclobaz 2.5 milligram, 5 milligram and 10 milligram. All the three are in mouth dissolving form so that you can give flexibility in your dosage form. We have recently launched vitamin therapy for migraine as per American Academy of Neurology. Riboflavin 200 milligram, magnesium 200 milligram and CoQ10 10 milligram, one tablet twice a day. Especially for school going children, pregnant ladies having migraine, and as an add-on to your conventional anti-migraine therapy. This webinar and all our earlier webinars are available on DigiNeuro YouTube channel. So when you go to YouTube, just type DigiNeuro and you will get a host of seminars, around 32 seminars. Most of them are neurosurgery conducted by stalwarts and masters are available on this. And today's webinar will be available tomorrow on this DigiNeuro channel on YouTube. Now I hand over the session to our today's moderator, Dr. Sandeep Chatterjee, one of the most prominent pediatric neurosurgeons of India. He is the current president of Indian Society of Pediatric Neurosurgery. He is also a chair of Education Committee of International Society of Pediatric Neurosurgery. Professor Sandeep Chatterjee is also a head of neuroscience at VIMS, Kolkata, and academic chair of Park Neurosciences, Kolkata. I have great pleasure and a privilege to offer the session to Professor Sandeep Chatterjee, which will take it forward. Sir, over to you. Thank you.
Thank you. Good evening and welcome to this webinar on two very interesting but different pediatric brain tumors. First of all, I would like to thank my colleague, Dr. Kaushik Sheel, who is really the brain behind the conception of these series of webinars. And Kaushik has played an instrumental part in getting all of this together. I would first begin by welcoming Professor Dattatreya Muzumdar, who is going to be the first speaker. And Datta, as you know, is a professor of neurosurgery at KEM Hospital in Mumbai, and really the most prolific neurosurgeon in that department. He's also the current editor of the Journal of Pediatric Neurosciences and has a great deal of interest in many subjects, but two of the subjects closest to his heart are neuro-oncology and epilepsy surgery. And he's going to be talking about the first. Datta is going to talk to us about the surgery of medulloblastoma, a tumor that is very close to my heart because this is in fact the first tumor that the Indian Society of Neuro-Oncology set up national guidelines on how to manage. So the ISNO adopted this as the very first tumor, and it was done coincidentally when I was president of the Indian Society of Neuro-Oncology. So it was a little biased that it decided to choose a pediatric tumor. But this is the first tumor we have national consensus guidelines on. And Professor Rajshekhar, who's also here, was very much a part of that committee. So Datta is really an expert in medulloblastomas, and I really don't want to stand between you and the expert's opinion. So Datta, all yours, and you can begin sharing the screen. So we'll take questions about medulloblastoma surgery at the end of his talk, and then we'll introduce the second stalwart who will take us through the surgery of brainstem gliomas. All yours, Datta.
Thank you, Sandeep. Can I share the screen? Can the screen be seen?
No, not yet, sir.
So you allow me to share the screen.
Yeah. You can, sir, you can.
Where is it? Where is the share screen option?
Yeah, at the bottom, sir.
Yeah, one.
Datta, if you go right at the bottom, it will be on green, shared screen.
Yes. Yeah, can we see?
Yes, we can see it. Now you can put it in projection mode.
Yeah.
Absolutely. Yeah. It's very clear.
At the outset, let me thank Professor Sandeep Chatterjee. Has been very kind. Thank you for the nice compliments, and also Dr. Kaushik Sil, Park Clinic, and the Indian Society of Pediatric Neurosurgery. As Sandeep has really mentioned this, we have worked quite a bit on these tumors when we were at the ISNO level, and also at the Indian Society of Pediatric Neurosurgery. And truly speaking, yes, that was a very collaborative effort that Dr. Sandeep Chatterjee and Dr. Rajshekhar and the entire committee had, with Dr. Jalali, we had formed the guidelines. And I think till this day, these guidelines are followed not only in India but all over the world in many countries. And I've been fortunate to present these guidelines at the Birmingham ISPN also, which was received quite well, with some few suggestions that they had given. So without going into this thing, I'll just straight away go to the topic. And I will just give a different concept, because a posterior fossa tumor is really a tumor which is a gateway to neurosurgery. So if somebody, a resident or a junior faculty, is starting neurosurgery, and if he does a posterior fossa tumor well, without any causing any great morbidity and obviously not mortality, then I think he's ready to do the rest of the neurosurgical work, including deep-seated tumors and so on and so forth. So I really feel that medulloblastoma amongst the astrocytomas and the ependymomas are a little bit different because they have a distinct phenotype. And obviously the therapy also matters, where the adjuvant therapy response is quite good. So it is the onus on the surgeon is extremely important to have a satisfactory surgical response, and the patient should be made fit to undergo this adjuvant therapy, which is so important. Because if the patient doesn't receive craniospinal irradiation or chemotherapy in high-risk cases, the entire exercise is futile. The tumor is going to, however good surgery you might do, the tumor is going to come back within a month or two, or maybe 3 months, because all these are grade 4 tumors. These are anaplastic medulloblastomas. So here the surgical strategy, now from a surgery for posterior fossa tumors, I would rather say that it is surgical strategy for a medulloblastoma. And in view of the recent developments, the considerations have also changed. So how I would approach a medulloblastoma as compared to what I did about maybe 10, 15, 20 years ago. So first, nothing replaces clinical examination. Nothing replaces a good clinical history. And obviously the next step is the radiology. So there has to be a good clinico-radiological correlation. Nowadays, radiogenomics has come in view of the molecular typing that we have been done. So preoperatively, the molecular typing, the surgeon has to know, because there is a fair amount of, I would say fair, not up to the mark, but fair amount of speculation that what kind of tumor are you dealing with and what kind of strategy you need to apply. Obviously, position of surgery, there are a little bit controversies. I prefer the sitting position, but it could be done in safely in a prone position or a lateral park bench position. So I would come to that a little bit later. The tumor characteristics are more important. You have to deal with the hydrocephalus either preoperatively, intraoperatively, postoperatively, and obviously the complications. So here I will go one after another, just highlight these points, and I'll show you a couple of videos as to how one should employ this surgical strategy into practice. So mainly clinical characteristics in our country, mainly the medulloblastoma, still people who come from far off in the interior of the country, we see large size of tumors. Which usually come with the midline syndrome, headache, vomiting, and ataxia. Some people come with blindness, secondary optic atrophy, and gross hydrocephalus. And usually, although we cannot test, but they usually can have a cognitive and intellectual impairment, which may manifest later in the life. So here is what I would say. So grossly speaking, if this is a busy slide, but you have to concentrate on basically 4 groups. So that is the WNT, SHS, Group 3, and Group 4. So for us, I think we should concentrate mainly on the WNT, which is a good prognostic indicator, and the SHS medulloblastoma, and obviously the Group 3 and the Group 4, the prognosis is not that good. Group 3 being having a very poor prognosis, usually seen in infants and a little bit older children. So barring the molecular typing, which we need to understand in light of the demographics, the clinical feature, genetic, gene expression, this is a must for any neurosurgeon who wants to deal with medulloblastoma. We cannot not, and we have as Dr. Sandeep Chatterjee has told, that we all have this Indian experience, remarkable, phenomenal Indian experience. We have already published our material, and we have also have the guidelines. So please read those guidelines in Neurology India, which have been published in 2017, and you will get a great deal of information. So as a surgeon, I want to know what is WNT, what is SHS, what is Group 3, what is Group 4. So here I come. So WNT, you will see in the top screen, the WNT is usually the classical medulloblastoma that we see, which comes from the lateral recess, from the lip of the rhombic lip of the brainstem. So it is close to the brainstem. It encroaches onto the fourth ventricle, and we certainly would say, okay, this is a WNT tumor. If you see on the right side, SHS are like desmoplastic medulloblastomas. They are lateralized, they are well defined, they have some peritumoral edema. They are maybe on the surface, a little bit subcortical, so they are very well amenable to excision. And Group 3 and Group 4. In Group 3, there is one less aggressive and a more aggressive type. So if you can see there, sometimes this may not show any great enhancement. That the entire posterior fossa is filled with the tumor. But having said that, and if you can see that there is a tonsil also which is affected in one of the slides. So here, even if you remove the tumor at a radical excision, still the prognosis may not be good. And similarly for Group 4, they are still seen in infants, and they can be of huge size and may have present with hydrocephalus. But we need to really concentrate on WNT and the SHS and the radiogenomics, which I was mentioning. This is also important for the surgeon to know before he enters into a medulloblastoma. So what I said was that if you have the WNT, which is a midline location, contrast enhanced, may show hemorrhage. If the predictive accuracy of the tumor on the MRI would be up to the tune of 74%, and if you see the SHS is 95%. So if you see the predictive value of diagnosing an SHS on the scan would be highest. And if you remove that, so if you diagnose SHS on preoperative radiology, you know that you have to remove this tumor completely, and then you might have a good prognosis. On the other hand, if you see the predictive value of WNT pathway tumors is 41%, but here, since the tumor is in close proximity to the brainstem, you may not go do an extended radical resection. The reason being that since these patients, WNT has the best prognosis amongst all, it is very amenable to radiotherapy and chemotherapy. So in the effort to do a heroic surgery, one may damage, and then we have lost an ability to give this worthy patient who would benefit with radio chemo, and it is lost to follow, because if this patient does not make it to the radiotherapy in time, because of the prolonged ICU care or rehabilitation or mutism or deficits, then we have lost this patient. So this is also an important sign. This is also published in the literature by the Tata Group. So I would really feel that this molecular typing and this radiogenomics should be form a basis of the armamentarium for the surgeon. So the goals remain the same. The goals previous also remain the same. We want a diagnosis because we want to do molecular typing. We want to decrease the tumor bulk. And obviously, in addition, we establish the CSF pathways. So as I told you, the aim of the surgery is safe maximal resection of the tumor, and there has to be no added neurological deficit. So this should be the aim, and this should be the only aim. Factors which affect the extent of surgery are the age, location of the tumor, radiological characteristic. I will come to, where you have to know. Apart from that, now because we are entering into surgical domain, whether it is a soft tumor, whether it is a hard tumor, whether it is calcific, whether it is encasing the neurovascular structures, the pica, infiltration of the medicerebral peduncle, brainstem, and so on and so forth. So here, you have to look at this scan very, very carefully. So first thing is differentiation from the other tumors, astro and ependymoma. A medulloblastoma will always be hyperdense on plain CT. You cannot not have a tumor. If the tumor is showing hyperdensity on plain CT, it is 99% medulloblastoma. Also, if it is hyperintense on T2, it is soft suckable. If it is hypointense, then you know that you are entering into a tumor which is a little bit hard and calcific. And sometimes it may also show invasion of the brainstem and the vascular structures. Spine screening has to be done at the outset if the patient is stable, or at least you have to advise the spine screening after you remove the tumor before we send the patient to radiotherapy. Sometimes the patient is very sick. Sometimes it is very infant which is few months old may not make it. So here the counseling becomes important. Whether you have to counsel and talk with the family whether there is any need or what will be the outcome of doing surgery in this case. Sometimes no treatment also becomes a kind of a treatment for the family and for the betterment of the family in the future. So all these adjuncts have to be there. You have to have a good neuroanesthesia, microscope, and skilled neurosurgery and a good rehab care. I want to highlight this particular paper which we studied, and this is essentially pre technology era and post technology era, and we have pointed out that post technology era after 2000 certainly there has been decrease in the hydrocephalus rate. The hydrocephalus control was better. The tumor excision was better. The complications were less amount of meningitis, CSF leak. So in the large cohort of patients, we have been able to prove that yes, definitely technology makes a difference. And within the last 4 to 5 years, with added knowledge of molecular typing and radiogenomics, we are even better. So my strategy would be that as soon as my posterior tumor gets admitted into my service, I operate it as late as possible. We would operate it on the day of admission or within 24 hours, and hence my indications for CSF diversion procedures are very limited. So I would tend not to do any CSF diversion procedures preoperatively. But yes, if the patient is clinically sick, gross hydrocephalus, we are not able to operate in time, then you can prime with steroids, do a VP shunt or a ETV, whichever is feasible, and tide over the crisis, and then come back for the surgery. Positioning, as I mentioned, I personally prefer, because I've been trained like that, we have been doing like that, and there is vast amount of experience. I can say it on my behalf because we have a good anesthesia who understands us, and obviously there has to be a neurosurgeon anesthesia compatibility. Otherwise, this sitting position, if you are not comfortable and the anesthesia is not comfortable and you have to just do it for the heck of it, it is not acceptable. So might as well, I would still be, although I'm a proponent of sitting position, I would still say for the safe position to do with will be a prone position and all the lateral or the park bench position. But for me, because the sitting position gives certain advantages that you can use both your hands, there is no blood in the field, you can no CSF allows the blood to come out, and you can remove the tumor comfortably. Only risk is air embolism, which you have to take care, and that can be reduced with a good anesthesia and a neurosurgeon combination. So this is the position which everybody is familiar with. I think you have to hold the position, the neck, head and the neck properly. The flexion should be such that it should not be obstructing the airway, and a linear incision is taken from the inion to the C2. The C2 might be exposed, but we don't usually remove the C1 and C2. We just stay short of the foramen magnum. So here, the safe maximal excision would, the issues relating to the safe maximal excision would be the following, where where there are cost constraints, the operation theater facilities, waiting list. So all these things have a bearing on the tumor. But I would say that as soon as you remove the tumor, if it is feasible, you should get a post-operative MRI done as quickly as possible before the post-operative changes set in. So within 24 to 48 hours, or do it 2 to 3 weeks later. The goal is gross total excision. You could do a parietal burr hole, which would aid in CSF drainage during and after the surgery. After the surgery, also it can be kept to, if there is a blood in the ventricles, or to drain the blood. So I would these are the basically these fine steps. But I would just say that the main important step is opening the cisterna magna, getting the CSF out, and obviously going from the superior pole of the tumor downwards. Depending on a surgical approach, it would be, if it is, you can do an inferior Vermian Spitling, if it is midline, lateral cerebellar, if it is a desmoplastic, you can go CP angle talovelar if it is projecting into the CP angle. If it is a superior Vermian, you go supracerebellar. And suppose there is a diffuse or leptomeningeal enhancement, you could just do a biopsy. So here is a patient who has a big medulloblastoma straddling the tentorium and pressing the cerebellum down. And here is what we achieved. With a total excision, you see the arachnoid has been preserved. So I have not even seen the structures beyond. So carefully, if you start piecemeal excision of the tumor and slowly debulk and take care of the bleeding, then at the end you would achieve this thing. You can see down there is a cerebellar surface, and anteriorly will be the pineal region of the posterior third ventricular surface. So here again, a large medulloblastoma, you can remove it safely. Although the tumor looks very huge, you can have a gratifying result. You can do multiple burr holes because sometimes the bone can be very thick, and you have to expose the transverse sinuses as a superior limit, and you can expose the foramen magnum or the C1 if the tumor is going a little bit inferiorly. The dura has to be removed quickly. This is at the end. Sometimes you can do a craniotomy, but I remove it piecemeal. I put the bone dust as well as the bone chips back. It doesn't make that much of a difference, but yes, if you do a craniotomy, then the chances of getting a post-operative headache are less. So here I would just show a small video where this is a high magnification video where I would just you can see that the cerebellum is swollen, the posterior fossa is full. So I just do 2 nicks at the superior surfaces and reflect the dura. And you see the assistant is just, as I come to the midline, there is an occipital sinus. So you have to quickly lift the dura up, otherwise you would have bleeding from the occipital sinus. Now, occipital sinus is bleeding is a good sign, a little bit bleeding, so that you know that air embolism would not occur. If the occipital sinus doesn't bleed, then you'll have to be a little bit worried. So in children, the occipital sinuses can bleed profusely. So you have to evert the dura as early as possible. Then remove the first step is to remove the CSF from the cisterna magna and get the system to be lax. So here I would rather do this and an intraoperative burr hole, parietal burr hole, rather than do a shunt preoperatively. And then, as I told you, then go from the inferior vermis and attack the superior pole of the tumor. You see, I use the suction in the right hand to debulk the tumor and dissect the tumor. And if you can see, I'm not going too much inside. You should not go too much inside because you don't know where the brainstem is and the vessels are. So sometimes you can use a handheld retractor. Sometimes you don't want a handheld retractor. Prolonged cerebral retraction is avoided, obviously, to prevent the cerebral mutism and injury to the dentate nuclei. So here, if you see, a handheld retractor is used in the one hand by the assistant, and you have your 2 hands free, and you can just debulk the tumor till and on the superior surface. I'm not going on the inferior surface at all, because you have to decompress the aqueduct as early as possible, early in the operation. And you can see that the brainstem is, you can see the normal structure there. You can see the floor of the fourth ventricle and the aqueduct. And as soon as you debulk, you can see that the entire system gets decompressed. So, and as you come down, then after you have removed the superior pole of the tumor, then you come laterally and then you come inferiorly. Now, mind you that the tumor might go into the lateral recess, and then you have to take care that you don't injure the perforators, the small branches of pica. Sometimes the tonsillar branch of pica may be the only supplying branch to the brainstem. So as far as possible, don't use coagulation unless you're forced to use coagulation. Even if there is some vessel which is bleeding, just wait, put patty, put Surgicel, put gel foam, wait. At the end, just see whether you really need to coagulate the vessels or no. So here, if you see that, and I'll a little bit go forward, because you can see that I'm removing the tumor from the lateral aspect now. And you can see from the lateral superior aspect, lateral inferior aspect, and the aqueduct is always seen there. And as what I do here usually is I just put a piece of gel foam and occlude the aqueduct to prevent air from going inside, and put a patty over it. I'll show the photograph, although I'm not shown in the video. And you can see that this sometimes there could be some vascular strands from the superior or lateral surfaces, and ultimately you have to just coagulate those strands. And you can see that at the end, this is the floor of the fourth ventricle that you see, and the choroid plexus will be there at the lateral end if you want to remove the tumor. So mind you that if you go too much inferiorly here, you would be in close proximity to the medulla. So you should not go too much into the brainstem. You should remain out the outside. You see, I'm at the really my suction and my my bayonet forceps it does not go too much inside the tumor cavity. So let the tumor deliver itself, and you coagulate at the end the small points. If you see, I'm not used coagulation during any part of the operation. And at the end, you just put Surgicel all around and inspect the cavity for any bleed or anything. The brainstem, the floor of the ventricle there should not be any blood or redness seen on the floor of the fourth ventricle. You give a good copious irrigation, not forceful irrigation, and that's the end of the surgery, where you can see that I've not removed the C1 here. I could manage it from the foramen magnum area as well. So this is a telovelar approach. Now sometimes the tumor presents in laterally, and you can see this is the vermis. So, and the tonsils are swollen here. So normally in a telovelar approach in an ependymoma, usually you can have a good space because the tonsils are not that edematous. But here, because of the brace pressure, the tonsils are quite swollen. And if you can see, I can easily go through this vermis and enter the tumor. But if the vermis is looking intact, why unnecessarily go through the vermis? Vermis is a very important structure to prevent ataxia and also some cognition-related issues. So you create a space, and you can see that I'm retracting from the tonsil away and exposing the tumor. You can see that the tumor is seen in the cleft between the cerebellum and the tonsil, and below the vermis. And as soon as I see the tumor, you see that the pica vessels are also there. So as soon as I see the tumor, I know that I am in the right area, and you can see that this is a pale tumor which is seen through the surface. And just try to spread out with your dissect it out. So whatever method you have, most of the surgeons would use the bayonet forceps in the right hand, the suction in the left hand. That's fine. So whatever methodology you use, you have to dissect it and split it rather than cut it or coagulate. So here you can see again, I'm not using any great coagulation during the start of surgery, but trying to just enter into the tumor. I've retracted the vermis and the vermis superiorly and laterally, and I'm going infravermian actually from the telovelar area into the tumor. So here, because the tumor is presenting out, you can see as soon as I can see the CSF coming down. Again, the same principle. that you go from the superior surface of the pole of the tumor and not go too much inside to prevent damage to the patient. The tumor will deliver itself like a baby is delivered through the vagina. So you have to, that concept if you keep in mind, if you can see that, as soon as you manipulate the tumor, don't pull any structure there. So you have to just give a small tug to see whether the tumor is free from this thing or it is stuck to the underlying structure. So no pull, no push, not going too much inside. Allow the CSF to do the dissection for you, remove the tumor piecemeal. Most of the time coagulation is not needed and you can safely remove this tumor as you see from the T-lobe area and without any splitting of any normal or incising or coagulating any normal structure. So that we can see that the tumor is getting sucked. If it is a soft suckable tumor, widely this thing. So there is, you can use the T-lobe approach if in case of this thing. So here it is, sometimes the tumor just protrudes out through the incision from the, in between the tonsils. And here what I would say that here when you put a gel foam across the aqueduct, it prevents the air from going out and prevents pneumoventricle. So that is a very important step, that you occlude the gel foam swells on its own and occludes the aqueduct. So we have published, and it's a normal maneuver which is used by most surgeons. And suppose the tumor is infiltrating the brainstem, as you see here, the floor of fourth ventricle. Do not try to remove it. As I told you, that this could be a favorable tumor, the wind tumor, and then this is amenable to, this will be taken care by the radio and chemo. If you try to remove this tumor, you might inflict damage to the brainstem. So that's an important tip there, that occlude the aqueduct, prevent air pneumoventricle, and remove the, keep a shell of tumor in the brainstem if you have to, and do not be overzealous in removing the tumor along the brainstem. So here there are different aspects where pneumoventricle would form. Sometimes it is in all the ventricles, sometimes it is in one ventricle, and sometimes it is into the parenchyma. So you have to deal with high flow oxygen and good supportive care. So there is a distinct entity of superior Vermean medulloblastoma, which I showed you the earlier picture. And sometimes you have to use the supracerebral or infratentorial approach to remove this tumor, just like you would remove for the pineal region. So hydrocephalus, I would say that I would advise, if you want to deal with hydrocephalus preoperatively, as I indicated, most of the times with intraoperative Burrow suffices. But if there is a hydrocephalus, then only two indications I do a shunt: extremely sick patient or a post-operative persistent progressive symptomatic hydrocephalus. These words, all these words are important. Post-operative persistent progressive symptomatic hydrocephalus. And why I don't do do the CSF diversion very actively is the reasons mentioned above. Sometimes it can cause upward herniation, fatal hemorrhage in the tumor, shunt infection, shunt malfunction, and sometimes it makes the surgery difficult because the CSF cleft between the tumor and the brainstem is obliterated. So at surgery, when you do a shunt and operate the tumor later, then sometimes you might encounter difficulty. The CSF cushion which would have been present is lost. So sequelae, as I told you, minimal retraction or no retraction, because the dentate nuclei have to be preserved. The dentate or rubrothalamic pathways are extremely important. So there would be some, this is the most important sequelae of post-operative tumor surgery, because it can last for a few weeks or few months. Recovery may not be complete. And the patient can be really morbid if we don't take, as I told you, there is a 50% chance of long-term speech and language apraxia. So we have to be very careful about retraction and not allowing cerebral mutism to be very, very prolonged. Sometimes we encounter recurrent medulloblastoma in our practice. It has to be managed on case-to-case basis. So there is no golden rule for that. You do the workup. Sometimes the patient and then decide whether you need to reoperate on the tumor or give irradiation or just give any myeloablative therapy. Sometimes you can get a long-term complication, radiation-induced glioblastoma, which we have reported. This young lady came with a Broca's area tumor 7 years after the surgery, and then this was a metastasis from a medulloblastoma. So sometimes it could be a secondary tumor, secondary neoplasm due to the chronic effects of radiation. So overall, I would say that if you take care of if you understand the tumor, and if you have to incorporate your molecular typing and the radiogenomics and be a neurosurgeon scientist, you can approach these patients, do a radical safe surgery with minimum mortality and morbidity. That is our I would call it dharma, because I think medulloblastoma patient not getting adjuvant therapy is more or less criminal, I would feel. So we are the onus is on surgeons, and I feel that if we do it with minimum morbidity and mortality, the adjuvant therapy is there to take care of the further course. Thank you very much.
Thank you, Datta. That was very, very informative talk. I think there's lots of questions we have, but before we go to questions, maybe we should ask some of our experts for their opinion. And in the group that constituted the National Consensus Guidelines on Medulloblastoma, amongst other people, we had, of course, Professor Rajshekhar, who is here with us. So the first thing is, I'm going to ask Professor Rajshekhar about, is there anything that Datta has mentioned about the technicalities of the surgery that you would like to differ from? Or is there anything that you do differently? And if so, we would like your opinion on why. Rajshekhar?
Yeah, thank you, Sandeep, for asking that question. Yeah, I come from an era where we used to do shunts routinely in the 80s. I'm not sure most of the audience is aware, but the first report of shunt surgery for posterior fossa tumors in children came from our department and was published in Journal of Neurosurgery in 1964. But we must think, put things in perspective. At that time, the mortality for this surgery was of the order of 30% to 40%. So with shunt surgery, they dramatically brought it down to around 80%. So VA shunt surgery became the norm for, I'm sure, so those of us who are old enough to remember that was the standard. For any posterior fossa tumor, you do a shunt first and then do the tumor surgery. So I was brought up in that kind of era. But like Datta, we do not do shunts at all as far as possible. And I agree entirely with him. I have never tried endoscopic third ventriculostomy, but shunts very rarely are put in. So I agree entirely with that approach. The point where we differ, means I personally differ, is the position. I must say that I was again brought up with this sitting position.
Yes.
So
yes.
I have even sat up, 2-month-old children.
Yes.
I used to sit them up, put them on some 10 pillows, and so that they would come to my eye level and I could operate.
Yes.
But I have stopped doing that from somewhere in 1991 or 92. Mm-hmm. And the air embolism is one problem. The issue also is, resuscitation. If you do get an air embolism, to resuscitate these kids in that position is an impossibility. The other point which actually you didn't touch upon is the fact that these bridging veins can bleed when the tumor is decompressed, especially large tumors. When you suddenly decompress it, the cerebellum falls away from the tentorium, and without your even noticing it, suddenly you start seeing the cerebellum in your face. And that is something to guard against. So one has to be very carefully do it. You made it look very effortless. Yeah. So the people who are starting off, the younger people, the less experienced people should remember that, sometimes this can lead to a disaster in the sitting position. So I use the prone position. Most of the surgeons now in our department use the prone position for posterior fossa tumors. And I agree with you that it is a problem as far as the blood is concerned. The blood can go in, and you need to guard against that with the gel foam placed on the opening of the aqueduct. And there is one more reason why I feel that you should guard against blood going in, and that is because it is a risk factor for developing hydrocephalus in the postoperative period. Yeah. We've just published that about a year ago in CNS, Child's Nervous System, where we've shown that it is a risk factor for developing hydrocephalus. So otherwise, I entirely agree with the way Datta has shown the excision of these tumors to be done. Yes, one more point where we do it differently. We almost routinely take off the patch of C1. Yeah. Because it's again, it's very easy. You can see the tonsils very well, and releasing CSF from the cisterna magna is not an issue at all. Again, that makes the process of releasing CSF very, very easy and comfortable. So that's one other point. But otherwise, I think the approach is almost similar to what you have shown. And I think you make the point that you should not be too aggressive around the brainstem. Yes, I think whereas for ependymomas, one needs to be extremely aggressive, but for medulloblastomas, we have good adjuvant therapy. And so we need to moderate, our excision. We shouldn't sort of leave a patient moribund and lying in the ICU, like you said, that can delay adjuvant therapy. So I think, yeah, so I think I have mentioned the points where we differ. Anything else, Sandeep, you want me to comment on?
No, I'll come back to you. One of the things that you mentioned about the blood, I have had the embarrassment of operating in a patient who didn't have hydrocephalus, and we did the operation, and if you use a telovelar approach, you often have the neck a little bit flexed, and then you start from the top, you get the upper pull down, as Datta beautifully demonstrated, and then your blood, if it trickles, goes trickling into the aqueduct and goes into the third ventricle. And I've had the embarrassment of finding hydrocephalus because I've got blood in the third ventricle post-operatively in a patient who didn't have hydrocephalus before the surgery. So, I mean, I don't know whether that's a problem. There is a problem, I think, of the prone position. I use the prone position, of course, more than the sitting. I very rarely use sitting, but because when I use sitting, I need to do 5 extra lengths in the swimming pool next morning to get my shoulders. But Ashish, we're going to come back to Professor Ashish Pathak, who's the other, the expert here. And Professor Ashish Pathak, as you know, has been a professor at PGI Chandigarh and then was a consultant in Hull Royal Infirmary before coming back to Chandigarh, where he's a consultant neurosurgeon at Fortis. By the way, Professor Rajshekhar doesn't need an introduction, but I forgot to tell you that he's the senior most neurosurgeon. Last time I introduced him and said, Professor and Head of Neurosurgery at CMC Vellore, he said, no, I'm not the head. But let us say the de facto head of neurosurgery at CMC Vellore. And I don't think anybody in this audience needs to be introduced to him. But we'll come back to Professor Pathak and ask Ashish, what do you think about these two things? The fact that if you do prone, you have a risk of having the blood gravitating into the third ventricle because you have your neck a little bit flexed all the time when you're trying the telovelar approach. And the second issue was the issue of position in terms of sitting position. So let's get your comments on those two, and then we'll talk about anything else that you want to differ in the treatment policy.
Thank you very much. I totally agree with Vedantam. I am again of the era where we used to do everything in sitting, and then we switched over to the prone position or concord position, whatever we want to say. And I've seen the difference between the two. We had air embolisms, and it is difficult to manage if you have an air embolism in a child in sitting position. The way that I do is almost the same what Vedantam was saying. For large tumors, I would definitely remove the C1 arch. Technically for 2 important reasons. First of all, I would lift the tonsils and have an idea where my floor of the fourth ventricle is going to be. And I'll put a patty there and gradually advance myself to remove the tumor or lift of the tumor if it is liftable very easily and gradually debulk it. I go to the top end at the very last, simply because the same reason that blood should not go into the third ventricle. So that's the way I will reach the top last, go creeping through the first, debulk the tumor, remove it from the surrounding area if I can sort of separate them if there's no invasion in the cerebellum. Be careful about the floor because that's where the invasion can be a big problem for us. And I tend to create something like a pseudo capsule. It is invading the floor rather than being overzealous. And that's obviously for the interest of a good outcome in a patient, because we cannot make out where there is a brain invasion on an MRI scan. Sometimes it looks that the brainstem might be invaded. Sometimes when you go there thinking that the brainstem is invaded, you find that no, it is not invaded. So I would remove the C1 arch. I would have a look at the floor of the fourth ventricle from below by lifting the tonsils. then debulk the tumor, gradually lift the tumor and go to the top and last. So that when I reach the aqueduct, I've already removed most of the things. And the moment I see the aqueduct, I put a small patty there, rather putting a gel foam. So it's all the same, with the whole idea that you don't sort of allow any blood to trickle into the third ventricle or the ventricular system. The other thing, of course, what I want to mention is that we used to do shunts earlier, as Vedantam said. But then later on, we have now gone to controlled EVDs. If you have to tide over the acute crisis of hydrocephalus, I put an EVD, but it's very controlled so that the risk of reverse herniation is minimized. And then, of course, take the patient up to the theater, after 12 hours or 16 hours when things are optimized. So that's the way now I do. And sometimes I keep that EVD for a little longer time, even though I might not be draining it, to be sure that there's no evolving hydrocephalus, and gradually sort of take out the EVD. And that's how I avoid hydrocephalus nowadays. And that's what we used to do in the West also when I was working there. The other thing, of course, two things I want to mention where we are still lacking, and it might be a worldwide phenomenon. First of all, in very small kids who are very sick, managing those children surgically is always a challenge. Question of blood loss and other factors are there. The other thing, of course, these children are very sick and they're vomiting. So in that situation, they are not a very suitable candidate even for surgery. And in our country, of course, giving chemotherapy is not a very easy thing. In all the places, we don't have the facilities, and these children, whether they would tolerate the chemotherapy and we can tide over the crisis, which is so much discussed in the literature, is not possible. So that's a big challenge for us. And the other thing, of course, which is there, we don't have any scope of neurocognitive evaluation in these children because they come in a very acute stage, and the cerebellar mutism, which is discussed, has got relationship to the pre-morbid neurocognitive function, as it is always claimed that it has got a bearing. Those who have got already compromised neurocognitive function because with the tumor or something else, they go into cerebellar mutism more easily. So these are the things which we still have not much control. And the other thing, of course, is the risk stratification has become slightly easier, as Dattatreya showed very easily. Now with the radiogenomic studies, we can give some idea about the outcome, but obviously that always remains a big question in the minds of the family. And there are various other factors which contribute to the outcome of these patients. And of course, the socioeconomic factor is there in our country. So that's all what I have to say.
Thank you, Ashish. I wanted to bring that issue up about below up or above downwards, because I have to say that I used to do it from above downwards, but because of this problem, I abandoned this. And now for me, I'd like to see the aqueduct last. And that's really what gives you the ultimate pleasure of seeing CSF coming into the third ventricle, into the fourth ventricle through the aqueduct, and you've done a good decompression.
Learn the hard way.
I learned the hard way. I learned the hard way because I have to say that. And I just tell you just an interesting point. I mean, after many, many years, I had to do a ventriculoperitoneal shunt for a very large medulloblastoma about 3-4 weeks ago. Because this was a child who came to us extremely sick. We didn't have the COVID status. And we didn't think without the COVID status, we should go in and do the medulloblastoma. So in the COVID era, we ended up doing an emergency shunt because I thought if he tests COVID positive, I'll just send him home. At least he has a shunt and can survive. So that's perhaps now become a new indication, which we never thought of before. But this is reality. I actually had a child very sick, massive hydrocephalus, huge medulloblastoma, not tested. Can't wait for him to be tested and the report to come 24 hours later. So we had to do a shunt. And then I thought if he's tested positive, we'll send him home. But that was just one interesting indication which we didn't have when we wrote up this protocol. Just while we are on the subject, since we have an expert surgeon amongst like Manas, and I'd bring Manas in and ask, I just can't help but ask for his opinion. Manas, of course, is the senior consultant neurosurgery at KIMS in Hyderabad. He is possibly the most prolific neurosurgeon anywhere outside the major centers that we have. and probably the most prolific webinar speaker in the last 3 months as well. So Manas, just two very quick observations from you. Number one, position. Number two, do you work from below upwards or above downwards? And then we'll take some of the questions we have from the audience very quickly.
Thank you, Dr. Sandeep. I have not done in sitting posture, nor I was trained in sitting postures. I have been doing in prone from the day one. And but we do a concord position so that it's easy to reach the top. Just a prone position is not enough. I have always found convenient to work from below up. Actually, when I saw a video of Mazumdar, I was thinking whether I'm doing wrong. But today I saw there are so many friends I have. So, because if you go from below up and then, one point I've seen this many times, just devascularizing tumor from the blood supply from the pica reduces the bleeding during the surgery. So that is what I do below up and then devascularize from the tweaks from the pica. And the dural opening we do differently. We make a crescent step opening where we first start the dural opening from below up, not from above below, like Dr. Mazumdar did. As he was telling that when it does the cerebellum pops into the dural opening. So when you do from below up, like a crescent shape, so we first let out the CSF from the cisterna magna, and then the dura becomes easy to open, and because it's a crescent shape, we preserve the internal occipital sinus and marginal sinus. So the venous drainage is preserved. So I've seen that after changing to that, my post-op edemas or post-op worsening has significantly come down.
Thank you, Manas. Any comments or questions from Kaushik? Kaushik, are you there?
No, sir.
Any comments, anything that you want to ask, Dr.?
No.
If not, I'll just raise one contentious issue. You know, when I was editing the various surgical bits that came in on management of medulloblastoma for the National Consensus Guideline, the biggest problem I had, and there were no two people that wrote the same thing, was about post-operative imaging. When do you image? When do you image the brain? When do you image the spinal cord post-operatively? When do you image the spinal cord if you haven't done a pre-operative imaging before? Because remember, there's the issue of leptomeningeal enhancement that occurs immediately after surgery if you do an immediate post-op. So when do you image, given the fact that some of these kids require anesthesia for a proper MRI? So I'll ask you for your opinion.
Yeah, so as I mentioned, most of these patients do not come with a pre-op spine screening. So once they do not come with a spine screen, it is very difficult for them to send back because they are sick and they have to be operated early. So almost always pre-op spine screening cannot be done in our setup. So most of the time post-op, if the patient is well, I like to do the MRI within 24 to 48 hours. Or if suppose that is also not possible, and for the anesthesia protocol, that safe is to do it after 2 to 3 weeks. Because that's the time when the radiation oncologists also want you to have the full workup for his radiation. So instead of repeating it in midway somewhere, best is to do it after 2 to 3 weeks, and also obviously do a CSF analysis also at that time.
And when do you do a post-op MRI of the brain?
Post-op MRI, immediately within 24 to 48 hours, it is feasible, I do the post-op MRI.
You see, this is what we wrote in the National Consensus Guidelines, and I was greatly disturbed by it.
Yes.
Because we said that you should do a repeat MRI after 48 hours of the brain. And we said, don't do a spinal MRI in the first 48 hours because you'll get leptomeningeal post-operative enhancement, so wait for 4 weeks.
Yes.
But the practicalities is that sometimes you need 2 anesthesias for these 2 MRIs.
So the other thing I want to just mention, that you have to start your adjuvant therapy as early possible in these cases.
Yes.
So in that cases, you need to have a post-op MRI anyway.
Yes.
And if possible, of course, nowadays as a routine, any posterior fossa tumor, our radiologist itself, they are inclined to do a whole spinal. Yes, so they have a view.
Yeah.
But I add a lumbar puncture to the same anesthesia which is used for post-op MRI, so that if you have missed anything on the MRI, at least the cytopathology can tell you more. So that's now we have started doing that routinely, which was not being done in the past.
I mean, one of the things we do, which I guess most of you will not agree with, is that we actually don't extubate our patients. We send them intubated to go down, have an MRI, and then they come up and get extubated.
That is a good thing. Yeah.
We save another anesthesia. So most of these kids have a post-op MRI from the operating theater, and then they come back and then get into the anesthesia room and get woken up, or just go to ITU like that and then get woken up. I don't know, it may not be feasible, but we found that way at least we don't struggle, because then you'd send the child 48 hours later for an MRI and the mother's weeping and the child is weeping, and it's a nightmare trying to get an MRI like that. But anyway, I think there are a couple of questions from the audience, Datta. Here's one. You got a very small child with a very large medulloblastoma, and as you try and debulk that medulloblastoma, there is horrendous bleeding. Do you stop? Do you try to take the whole thing out? Given that some of these children may have a pretty much of a high volume blood loss, given that they may be small and malnutrition children. So how do you manage this if you have a big medulloblastoma and it's bleeding a lot and you're trying to take it out? And the second question I'll put in that has come together with that, what is the role of CUSA ultrasonic aspirators?
Okay. So I would answer the first question and take it the second question later. As I told you that if the patient, if it is a small child, very small child who has a big posterior tumor, most likely you are dealing with an ATRT rather than a medullo. So as it is, as I showed in one of my slides, that I have to, when I see this child, I have to counsel, talk to the family more and in great depth and detail what are the expectations that they have, and have a good interaction with them, that yes, there is a possibility of any catastrophe intraoperatively where I might have to stop, and maybe after stopping also I don't know what is going to be the outcome of the patient. So what if by chance, suppose everything goes well and if there is horrendous bleeding, usually the first person to ask me to stop is the anesthetist. The anesthetist tells us, doctor, please stop, you cannot go further. If you go further, you are going to have a dead patient. So obviously all of us have gone through that so many times. We have had so many catastrophes intraoperative. We have burnt our fingers many times. But over a period of time, I have become wiser. I said, okay, if the anesthetist gives me time to time signals that something is going wrong, I would not hesitate to stop wherever I am, and then maybe come at a later date and explain whatever has happened to the family.
What about hemostasis at that stage? You decide you're going to stop, it's still bleeding. What would you do? What advice would you give to younger people or people less experienced than you, like me, for example? How do you stop the bleeding?
So now the bleeding has to be, I use the same techniques. You have to put pressure, you have to wait, you have to irrigate. You have to allow the anesthetist time to get the fresh blood, the blood products, get the investigations done, and try to, you can use the pause or something like that. But I feel if the tumor is bleeding and suppose if it is not stopping, and if the anesthetists are not comfortable with me, I would not go ahead. I don't want to have a dead patient after removing the entire tumor and have no heart and no this thing, and then go all through the sequences where you have to declare the patient post-op. So as far as possible, if I have to control the bleeding, then I have to remove more tumor, because unless I see the bleeder and the tumor is the way, I cannot control the bleeding. It is not going to happen that I just coagulate on the surface and the bleeding is going to stop. So if it is continuous bleeding, I have to go on removing the tumor within that safe limits of what the anesthesia and all the armamentarium, the blood and the blood products and everything is there or not. As far as CUSA is concerned, I'm comfortable with the suction dissector that has been given to us in our ancestry by Professor Goel. So it is very hard to come out of that now. But yes, if somebody is able to use CUSA, then it uses the same principle. So, but I would say that if you don't have a CUSA, still it is quite doable to do whatever you have. So it doesn't make a difference. It all just makes what you are used to a particular technique.
Another quick question that has come: how do you prevent pneumocephalus in the ventricles? Quite often after removal, you end up with pneumocephalus. How do you stop that?
As I told you that I showed you the pictures where I immediately see going from, that's what the below to up technique, where you try to prevent that. But suppose if I go from above to below, when I see the first the CSF coming out, I see the aqueduct very quickly early in the operation. As soon as I see the aqueduct, I put a gel foam there, put a patty, and it just blocks this thing. The CSF is coming out. It is coming down the fourth ventricle, but no large amount of air is going inside. So my first measure to block, prevent this thing is to prevent a pneumoventricle. Although, even if you do these maneuvers, you are going to have some air seen in the ventricle post-operatively. In that case, you have to give the patient, be supine and give good high flow oxygen. And usually oxygen takes care and the air gets absorbed. Another thing is the nitrous. Many people are not using nitrous, but if you are using nitrous as anesthesia, then maybe half an hour, 45 minutes or 2 hours before the closure, I ask the anesthetic to switch off the nitrous so that the expansion doesn't happen in the ventricle. So these are the few maneuvers I do. Most of them, as I'm in the later part of my series, because I'm tuned to that, I just block the aqueduct as soon as I try to see the aqueduct. So although having said that, my patients do have pneumoventricle, but symptomatic pneumoventricle incidence has gone down.
Great, thank you very much. I think we're coming to the end of, we've much exceeded the time for the...
Thank you, Sandeep. Thank you, all the panelists. I've learned a lot from you all.
I will just end with a comment by one of the youngest neurosurgeons who's tuned in.
Yeah.
His name is Manoj Kumar Bhattacharya. And this young man has made a comment which he wants me to read out to you, which is that sitting position is a great position to do myeloblastic. You have a great supporter at our clinic.
Yeah.
Great. On that note, I think we will move over to our next speaker, and that is Manas, Dr. Manas Panigrahi, who's a senior consultant neurosurgeon at KIMS in Hyderabad. I've already introduced him. Manas is really a role model neurosurgeon for a lot of people, including myself. And we are all waiting to hear him. So Manas, all yours. Manas is going to talk about the surgery of brainstem gliomas.
Thank you, Dr. Sandeep. Can you see my screen?
Yes, sir. Yes, sir. We can see.
Okay. I have 20 minutes. It's not 20.
Yes, take your time.
So thank you, Dr. Sandeep and Dr. Kaushik When Kaushik had initially planned that this should be more of a surgical session because live surgeries have stopped because of corona pandemic. So he had told that we'll start a session where we teach surgery to the residents. So most of my lecture is oriented to residents. So it may be too basic for the panelists. I hope you will not mind, Sandeep. Brainstem gliomas are not as common as medulloblastomas. Means many because post-fossa tumors day in and out, many people operate. But brainstem gliomas they are very uncommon. They form only 25% of the posterior fossa tumors, and they are more common in 5 to 10 years of age. But then they have a second peak at 30 to 40 years. I'll be seeking more on the pediatric brainstem gliomas today. There are a lot of classifications starting from 1985 by Epstein to in 1996 by Albright et al. In Chalks et al. In 2000. Basically, everybody has divided the tumor into focal and diffuse. And all of us know that focal can be operated and diffuse should not be operated. Unfortunately, diffuse constitute 80% of the pediatric brainstem gliomas. So very few brainstem gliomas can be operated in children, whereas 50% of adult brainstem gliomas are focal, so they can be operated. But then Dr. Mehta, he observed and he published that it's not that all the diffuse gliomas cannot be operated. At least some of them, there is a subgroup of that called expanding variety, where the MRI, they show a well-defined enhancement in the MRI, and they have a slow progression of the clinical symptom with hardly any motor disturbance, or they have intact motor disturbance, and size maybe more than 2 centimeters. This expanding variety is a subgroup of diffuse pontine glioma, which can be operated and they have a good outcome. Now, how do you identify this subgroup of diffuse pontine glioma which can be operated? Now, this was published by Dr. Sridhar from Chennai. He said that if one does a diffuse and tensor imaging in diffuse pontine glioma, and if one can demonstrate whether the tracts are compact or infiltrated, one can decide whether it's an expanding type or a diffuse infiltrating type. And if its tract is displaced, then it can be taken as treated as focal glioma and can be operated. Now, the focal glioma, as I told, in children constitute 80%, but some of them, if you do a DTI, they can be operated if they are displaced or they are the expanding type. Unfortunately, the diffuse pontine glioma have a very bad prognosis. They have a median survival of 8 to 12 months with adjuvant therapy. Now, what is good is in the focal brainstem glioma, the median survival is more than 5 years, as many of them are low-grade glioma, unlike DIPG. So these are the group of patients in children can be operated, and fortunately in adults, half of them are focal. And again, but then the contrast is many of the focal gliomas in adults are higher grade. So they have a worse survival, like 1 to 2 years, unlike children. Whereas the diffuse gliomas have a better survival in adult. So, and these are the group, again, half of them can be operated if one does a DTI. Now, to divide the surgical approaches to brainstem glioma, it is easy to follow this classification to divide the lesions involving the midbrain, the pons, and the medulla. And lesions involving the ventral part, like the tegmentum of the midbrain and tectum of the midbrain, the ventral pons and the dorsal exophytic type of dorsal pons, or the ventral medulla or the dorsal exophytic like the cervicomedullary type. So, and while we're discussing approaches to each example from each one of the regions. Now, pontine, this is a classical MRI of a pontine glioma where more than 50% of the margin is diffuse and it involves in axial scan more than 50% of the axial. But if it's less than 50% of the axial brainstem, it can be taken as focal. But it is a very subjective way of dividing focal or a diffuse brainstem glioma. Similarly, if one takes this, if one sees in the OP similar glioma, one will assume it is a diffuse pontine glioma and send them for radiation. But then when one does a diffuse and tensor tractography DTI, one can see that the tracts are displaced to one side, and so this becomes something which is a surgical case for among the diffuse pontine group. So it's important to do a DTI in all suspected cases of DPIG. Now, this is again another case which was referred to as a diffuse pontine glioma, where the whole pons was involved, means more than half of the pons was involved, but the only thing, it had a good margin and there was no enhancement. And this is the scan, the T2. You can see here it's a large lesion. And when we did a DTI, one can see here that the tracts are this side. And again, this is a good case for surgery. So if you have a lesion in the pons, the approach depends whether it is a posterior or anterior. If it's posterior, it's the standard posterior fossa approach, as Dr. Mazumdar explained. If it's anterior, one can do a subtemporal approach, pre-sigmoid approach, or a frontotemporal orbitozygomatic approach. What we do is a combination of subtemporal or frontotemporal orbitozygomatic, and I'll give an example of that. The classical position is like a supine position with head turned and lateral flexion, so that subtemporal approach is easier. The craniotomy usually involves a little bit of subfrontal area, so that one can let out some CSF from the interoptic cistern, so that the temporal lobe becomes lax. So one need not place a lumbar drain to have a temporal lobe relaxation. The other important point is always drill of the sphenoid ridge flush with the anterior surface of the temporal bone, so that whenever one does a temporal lobe retraction in subtemporal approach, the temporal lobe or the tip doesn't get crushed against the bone. So this is a very important point, that the sphenoid ridge has to be drilled flush with the temporal bone, anterior surface of the temporal bone, and subfrontal exposure also should be there. instead of doing classical subtemporal, we use add a skull-based approach, like remove the tip of the petrous apex intradurally, so that gets a wider exposure and less of retraction of the temporal lobe. Normally, we remove the zygomatic arch also whenever we plan this approach. Now, this is the intradural part of the petrous. We do not do an extradural petrosectomy. Intradural, after the temporal lobe is retracted, we identify the petrous ridge. We feel for the posterior margin of the Meckel's cave, as well as identify the arcuate eminence, and then the line joining the lateral end of the arcuate of the Meckel's cave and the arcuate eminence. This is the LMA line. Remain medial to it and drill off this part of the bone that will lead to the posterior fossa. So this is the part of the bone which has to be drilled. As I told you, this is the arcuate eminence having the geniculate ganglion and the facial, and this is the lateral end of the Meckel's cave that corresponds to the foramen oval. Now that is the place where the GSPN lies, and the ICA also lies in that plane. So if one remains medial to it, then one will not damage the GSPN or the ICA, and drill out this petrous apex intradurally so that it widens the exposure. So this is what we do after doing a subtemporal temporal craniotomy after zygomatic arch removal. Feel for the Meckel's cave with a Addison dissector, then feel for the arcuate eminence, feel for the petrous ridge, then identify the triangle as I explained, and then reflect the dura. This is the line of the GSPN, reflect the dura, identify the medial edge of the petrous ridge, and drill this part of the bone. Once that is drilled, one can identify the posterior fossa dura and the arachnoid here. Let out CSF from the posterior fossa dura, and then the superior petrosal sinus comes here laterally. One can easily coagulate and incise it or use silver clips. It's easier to cut the tent from lateral to medial rather than from medial to lateral, where one needs to do more of temporal retraction. So here the posterior fossa dura is exposed, CSF let out, the superior petrosal sinus is ligated, and the tent is cut from the lateral till the free margin of the tent. So this gives a wide exposure of the pons region. And once you reach the pons, now this is the fifth nerve. The ideal point to enter the pons or the safest zone is anteromedial to the root entry zone of the fifth nerve. This is the fifth nerve. So the safest place where to enter is the anteromedial part of this point. So this is a video showing the steps which I explained. The first is to open the dura on the frontal side and let out CSF from the interoptic cistern. Once that is done, the temporal lobe falls off. It's easy to have the space to retract. Then identify the LMA line. LMA is the line between the arcuate eminence and the lateral edge of the Meckel's cave. Use a diamond drill to drill off the petrous bone. Always be careful that one should not go across this line, LMA line, because that is the GSPN and the ICA. In children, it is easy to drill because the bone is soft. It's quite fast in children. In adult, it takes time. And then coagulate the superior petrosal sinus. Use silver clips if required, if it doesn't stop with coagulation. And then use a 11 blade to cut. Let out CSF from the posterior fossa. And gradually retract till one reaches one can see the fourth nerve here. If one is incising the tent behind the Meckel's cave, always the third and fourth nerve will be entering in front. So one need not worry about damaging the fourth. So here I'm protecting the fourth nerve, and then I've completed the division of the tent. And this is the tumor. This is the scan which I have shown. Space can be widened by reflecting the tent using a tenting suture. This is the fourth nerve seen there. And this is the tumor, exophytic tumor from the pons. Tumor dissected from the fourth nerve. And this is the fifth nerve. So here the tumor was exophytic, so there's no point of finding an entry point. But if it's not exophytic, if it's purely intrinsic lesion, one has to enter in the peritrigeminal root entry zone of the fifth nerve. I can see here, this is the fifth nerve. Internal decompression of the tumor was done till we found a plane of cleavage. And finally, it is closed. And this is the patient on the third day before discharge. So if you have a brainstem pontine lesion, the safest point of entry is anteriorly and inferiorly to the root entry zone of the fifth nerve. So this is the fifth nerve. So if one is doing anterior petrosectomy or FTOZ approach, this is the entry point. But one does a retrosigmoid approach, also the inferior, just below that or inferior, that is the entry point. So like this case, where this is a lesion of the pons in the lateral aspect. So we did a retromastoid, retrosigmoid approach, and the entry point was below the root entry zone of the fifth nerve, below and anterior. So that is the safe entry zone. So in a brainstem tumors, the most important point is how to enter and how to, so that the you do not add morbidity or mortality to the patient. Now, how to approach a lesion in the dorsal pons? This is a case where the dorsally exophytic into the fourth ventricle, and this is another case which is indenting into the fourth ventricle in the lateral part of pons. In both the cases, we did through a midline posterior fossa suboccipital craniectomy. So as I was explaining earlier, that when one position for a posterior fossa, it's not only flexion at the occipito-cervical junction, but also at the cervicothoracic junction. That is the concord position. So that is easy to see the tip of the aqueduct, and then lift the head end is elevated so that it becomes flat. But it's important to fix the body so that it doesn't slide down. It's a midline craniectomy is done, starting the incision starting from the internal occipital protuberance till to the C2, as Dr. Datta has explained. The classical way of opening the dura is a Y-shaped opening, where the internal occipital sinus and the marginal sinuses are incised and coming up to the dural incision coming to C1. But as I was explaining, here the bleeding happens in both the marginal sinus, and sometimes you lose a lot of dura. So when you have to close the dura, you need a duroplasty. But if we change to a crescent shaped opening, where only one side dura is opened and the occipital sinus and marginal sinus drainage is preserved. And so the dural loss, if there is a coagulation or putting silver clips, is very minimal. So hardly we need to do a duroplasty in posterior fossa. Most of the time, 90% of the time, we have been successful in doing a primary dural closure in the posterior fossa lesion. Now this is how it looks like. We start from below and let out CSF from below so that cerebellum becomes lax, and then open the dura to the top and turn it towards the along the transverse sinus towards the occipital sinus. So this is how it looks like, and visualization of both sides is not at all a problem. You have to just need to turn the table right or left, or sometimes work from the right side or the left side of the patient, and one gets a very good visualization at the end of decompression. The safest entry point in a dorsal pons is either the suprafacial triangle or the infrafacial triangle. One can see the facial colliculi in the brainstem in the floor, and work laterally. Supralaterally is the suprafacial triangle, that is a safe entry zone, or inframedially is the infrafacial triangle. So these are the two areas which are safe in pons. But this is the video of the scan what I showed. As I was explaining, you start from below the dural opening, let out CSF. And then if it's a medullo, we work from below. So this is a brainstem glioma. So open the telovillar approach. Confirm the facial nuclei with a stimulation. So this is the place where we identified the tumor. Identified the facial nerve to the stimulation. And then we did work through the suprafacial triangle. Here there was no stimulation. One can also make out that it's more avascular and bulging there. To make a brainstem incision, one can use a laser or a sharp knife. And then this was a cystic tumor with the wall. The wall was dissected. We had given fluorescein, that's why it was looking greenish when we changed the fluorescent light. The capsule is excised. A sharp hypodermic needle is a very good dissector. This is the plane between the tumor and the normal brainstem. Fortunately, as it was cystic, it was easily excised. And at the end, hemostasis was achieved. Now, what do you do for lesions of the midbrain? Midbrain, it can be lesion from the tectum or from the tegmentum. Most of the tegmentum lesions, either they bulge into the third ventricle. So if you have third ventricular bulging with hydrocephalus, one can do an endoscopic third ventriculostomy as well as have an endoscopic biopsy of the lesion. Like this case, it was from the tectum, but it was bulging into the third ventricle. You can see here that the widened third ventricle. So we first did a biopsy and confirmed that it was a pilocytic astrocytoma. Then we did a excision posterior approach and then did an excision of lesion. This is another case where, again, first we did a third ventriculostomy with an endoscopic biopsy. And this is another case of a 7-year with ataxia, where we took care of the hydrocephalus. First stage was an endoscopic biopsy with third ventriculostomy, and second stage was tumor surgery. Depends on the whatever biopsy. If we get a high-grade tumor, we directly send for adjuvant therapy rather than going for excision. And this is the video of a third ventriculostomy. Now, fortunately, when we introduced the endoscope, there was a spontaneous third ventriculostomy. You can see here, the third ventricle is already opened up. So we didn't have to do any third ventriculostomy. But then what we did is a biopsy of the posterior third ventricular tumor. This is the interthalamic adhesion, and this is the tumor bulging into the third ventricle. You use the Fogarty catheter for making an incision, and like when you dilate it, it makes an incision. There is an already avascular incision made just because of the pressure, and then biopsy. So this is what, instead of using monopolar, use the Fogarty as a knife. And once that is done, then biopsy was done from the tumor. So while doing the biopsy, what is important is one should not pull, but rotate. Rotate clockwise and anti-clockwise. Under vision, the tissue should be separated from the main tumor. If one pulls without separating, then one can have inadvertent bleeding, and that can cause problem. So it's always hold the tissue and then do clockwise, anti-clockwise rotation till the tissue is separated from the main mass of the tumor, and then remove the instrument. That is what is important to prevent complications or intraoperative bleeding from tumor while doing biopsy. Now, that are the lesions which are bulging into the third ventricle. Now, these are the large tumors of the tectum. They are bulging posteriorly, and this is another lesion of the midbrain, which is dorsally situated. Now, these are the lesions which has to be done through a posterior approach, either a Stein's approach or a combined supra and infratentorial. Stein's approach is easy with sitting posture, but as I'm not comfortable with sitting posture, I usually do a combined approach in a prone position. I do always a supra and infratentorial combined approach. This is what we do differently. We do prone position, make an incision like this, and open both supratentorial, infratentorial, and again cut the tent from posterior to anterior so that we have a wide exposure and of the tectal area, and then do decompression. Now, if one exposes the tectal area, which is the best place to incise. I can see here the fourth nerve. The best place to incise is parallel to the fourth nerve, either below the level of colliculi or above the level of colliculi, parallel to the fourth nerve. So there are two safe areas, either supracollicular or infracollicular, parallel to fourth nerve. But if you have a lesion, so this is one case where what I'd shown endoscopic biopsy we had done. It was pilocytic astrocytoma, so we did a posterior approach, and then this is the post-op scan. Now this is a cystic lesion, again posteriorly situated, which was done a combined supra and infratentorial. I'm sure many of you can do with only a Stein's approach, but I'm comfortable as with combined approach, as it's a wide exposure and achieving hemostasis is easier. So you can see here that again the cyst wall is removed and till we identify the normal tissue. This was a solid tumor where it is done in 2009. Still the patient is under follow-up for the past 11 years with no recurrence and no adjuvant therapy. This was a low-grade glioma, and only thin plate of tumor was left along the tectal plate, and this was done with a combined approach. Again, this is a 13-year-old girl. Again, this was operated in 2011, and this is a not 2011, earlier than this is a post-op scan in 2011, and without adjuvant therapy, it was a low-grade glioma and follow-up. Actually, this patient had presented with gelastic seizures, but this is an adult, 27-year, and this is the post-op scan, and now he's free of gelastic seizures. This was a 14-year-old boy who came with tremors and weakness. The video which I had already shown, and this is the post-op scan. Now, having finished the dorsal midbrain lesions, I'll give an example of a ventral midbrain lesion. I'll not talk about medulla because I'll be crossing my time. So the ventral midbrain usually done through a transsylvian route. This is another ventral midbrain lesion. So what you can see here, the cerebral peduncle is involved. It's a thalamopeduncular lesion, peduncle, the cystic part going to the thalamus. So these are the lesions which one has to do through the anterior approach or a transsylvian approach. One can do subtemporal also, but we did through the transsylvian approach. So the transsylvian approach, if one does an FTOZ, it gives a wide exposure. The safe point of entry is at the exit zone of the third nerve, lateral to the exit zone of the third nerve. So that is a safe point of entry if we do not find anywhere tumor is bulging. But if the tumor is bulging, then that is the safe zone. And whenever one incises, it is always one has to do vertical incision parallel to the corticospinal tract. Like this lesion, which is bulging on the surface, where one has to incise vertically parallel to the corticospinal tract, like this vertically, so that one does not damage the corticospinal tract. Now, this is a video of that case, which we did through a transsylvian approach. In children, the skull-based approaches, because the bone is soft, is faster. So skull-based techniques are really useful in children. Though with experience, people can do with a standard TDML. So this is the ICA. We're working lateral to the carotid. This is the third nerve, and this is the tumor cerebral peduncle. We made the tumor was seen on the surface. We made an incision vertical to the or parallel to the cerebral peduncle. and decompression was done with CUSA. We have been trained, unlike Dr. Mazumdar, who KM, where they're used to without CUSA, but we have been trained to use CUSA only. Many times we feel that we should not do without CUSA. Probably that is not right. But the CUSA has its own advantages. And this is at the end of the tumor excision, the cavity of the tumor. And when you use a fluorescein, one can see here the tumor. This is the thalamopeduncular lesion cystic one, the fluorescence tumor. Again, it was excised, and this is the normal plane between the tumor and the normal plane. Do you have time for medullary tumors, or I'll stop here?
No, go on.
The medullary tumors can be ventrally located or dorsally located. But this ventrally located lesions, you can see here that there is a thin layer of neural tissue, so it's not good to do through the fourth ventricle. So here it is better to do to the retrosigmoid or a far lateral approach. Whereas this lesion, a cervicomedullary lesion, which is dorsally exophytic from the medulla and the cervical region going up to the C3, this is again a midline suboccipital craniotomy with cervical laminectomy. A posterior approach is better. This is another lesion with a 9-year-old male came with ataxia, had again large lesion in the cervicomedullary area. The safest zone of entry is the infrafacial triangle or the midline, the posterior median fissure, or the posterior intermediate sulcus between the gracile and the cuneus fascicle, or the posterolateral sulcus. So these are the three zones. Ventrally, there is no safe zone except that wherever it is bulging. So this is the lesion of the intra-op picture, but here the tumor, as we routinely do a crescent subdural opening, and to the tumor dissection, find the normal plane of cleavage, use the stimulation intermittently whenever required, use CUSA and stimulation. This is the stimulation for the corticospinal tract and the nuclei. And just follow the principles of surgery, microsurgical principles of normal tissue and the tumor dissection. Hypodermic needle is the best dissector, cheapest, and can be, we get many disposable things for 5 rupees. We don't need to buy a arachnoid knife, which cost it cost in a few $100s. And this is the post-op scan. There is residual tumor, as Dr. Majumdar was explaining, that if there is brainstem involvement, it is better to leave. The quality of life is more important than just having the orgasm of excision. So whatever we had operated, we had published of the cases. Of the low-grade gliomas, the survival has been good, more than 4 years, whereas the high-grade gliomas had less than 2 years of survival. We had complications, mortality of 3%, and 10% of the patients developed additional deficit, which improved over 3 months' time. So the take-home message is focal gliomas, either in children, 20% of them need surgery. In adult, 50% of them need surgery. In adults, diffuse glioma have a better prognosis. In children, focal glioma have a better prognosis. But then all diffuse gliomas should not be sent primarily for primary radiotherapy. DTI has to be done to differentiate whether it is operable or not. And wherever it can be operated, surgery probably has to be offered, and it gives a good result, at least in our with our experience. Thank you for your attention.
Thank you very much, Manas, for a most beautiful and eloquent talk on brainstem gliomas. I could not resist but show you the backdrop of a most beautiful sunset that I've been witnessing sitting here on my roof in Shantiniketan while you've been giving this exotic talk.
I was about to say that. It's a real background or very nice background. Yeah.
I always learn so much when I hear Manas talk. I love that that concept of using the Foley catheter to make an incision in that tumor, for example. And there is so much. But I think we have to get our experts in. And Professor Rajshekhar, would you like to comment on this very eloquent and very thorough discussion on brainstem gliomas that we've just had?
Thank you, Manas. I think you've covered the various approaches to different parts of the brainstem. I have a different philosophy to the midline gliomas of the pons. I'm not convinced that there is this so-called focal type and the diffuse type in children. I think if they have the H3K27M mutation, I think they're going to behave the same. So I do not believe that surgery is really useful in that group of patients. I agree with you entirely. The midbrain, the thalamopeduncular, the cervicomedullary, yeah, we need to go after those, no question about it. Adults, there are a group of pontine gliomas in adult, let me put it like young adults, you know, in the 20s, in whom I have taken them out. But in a child, like a 6-year-old child comes to me with 3 weeks history of progressive dysfunction, brainstem dysfunction, I don't care what the MRI shows me. I know that this is going to turn out bad for the child. And I don't think surgically I can help this child. So I think one has to be very, very careful about sending a message that these tumors can be helped surgically, including whether you do DTI, whether you do any kind of MR imaging. I do not think we can really help them very much. And it's the biology that's ultimately going to determine their outcomes. So that is one place where I know I've heard Dr. Mehta present his data several times, and I've always had this concern because I don't get to see the long-term outcomes in these children. I don't get to know what has happened. Yeah, in immediate post-op, they may have done reasonably well, but in the long term, because a lot of the so-called T2-weighted hyperintensity, that's the white on T2, is all tumor. Is all tumor. It's not just the enhancing part that we are bothered about. The rest of it is also tumor. So whatever we see as white is tumor, and we just cannot take most of that out. So, I mean, I know we can sort of debate this, and I'm sure you have good experience in some of these children, but that's my take on it. And I'm very hesitant to recommend surgery in that group of patients. So, yeah, that's, I know I may be sort of provoking you, but that's my take on children. Adults is a different ball game altogether. But in a child who presents with a rapidly progressive brainstem dysfunction, I don't go after them.
Yeah, I totally agree. Like if it's a short history, then they don't do well. But as Dr. Mehta had published, people who have very less of clinical symptoms and little longer history, they do well with surgery. It's not and totally dependent on DTI, but then if a patient comes with very few clinical symptoms and the MRI shows diffuse pontine glioma, they should be given a chance. That is what point I wanted to stress. And they have come with a longer history, not with 2 weeks history, 3 weeks history. Obviously, it tells that they are aggressive tumor. And whether they're histone positive or not, it all depends on the biopsy report only. We do not know it preoperatively, it will be histone positive.
So my quick query would be, why not do a stereotactic biopsy, find out what the molecular biology is, and then go after it. If it is something which you believe can be helped, why not take that approach?
Yeah, that I never thought of, because in a children doing a stereotactic biopsy also involves a general anesthesia. So
but the procedure is very safe, as we have shown with a huge number of patients. It's a very safe procedure. You can accomplish it very quickly, and therefore then you won't sort of subject a large number of these children to very, very prolonged or risky or
we have not operated many tumors.
Yeah, it may not be in your hands risky, but if you send this message to the younger people that, these are surgical lesions, then I'm concerned that a lot of them will be unnecessarily damaged. Anyway, I think we can talk about this.
Yeah, in fact, it's interesting, but you may be interested to know that the French group are now involved in a trial where they're giving upfront chemotherapy to these children and not doing direct surgery, comparing them with historical controls that they did surgery and looking at quality of life measures at the end of 6 months and 1 year. And I think that'd be quite interesting because, I don't know, I mean, Manas is an exceptionally talented surgeon, but I often feel that this is devastating surgery for a 4-year-old. And what do we achieve at the end of the day? This is also a very big question. And parental expectations become very high if they go past the surgery and you know, they recover and go home. And I have a huge problem when they come back after about 4 or 5 months, and I feel fairly helpless. But I mean, this is exceptional surgery that we've had demonstration of. And if you can operate like that, I guess you can take them.
No, I just want to emphasize that only 20% of the children with suspected DIPG, they come for surgery, because other 80% they still show that DTI has an infiltrative type. We send them directly for radiotherapy. It's not that all patients we offer surgery. It's only 20% of them.
But the problem is the children that are younger than that cannot be given radiotherapy also. That's a big problem area in this country.
Yes.
Dr. Ashish Pathak. Ashish, you need to unmute yourself.
Yeah. I have a little bit of different opinion with Vedantam here. You know, some of these patients, if you read the radiology carefully, there would be what he exactly described, a focal expansion. And if somebody has heard Charlie Tew showing, similar things, they actually expand at the expense of having a lining of the brainstem all around it. So one has to really go to the console and see. And in these cases, you can definitely make out that this has expanded to the extent that looks like a DPGI, but it is not DPGI exactly. And in this situation, it has been shown, and one has to really have all the facilities and the technique and the tenacity to sit for hours to sort of, evaluate the whole thing. And these do work. And I tell you, very recently, there was a girl who drastically came down in neurology. And within some 2-3 months, she was not able to walk, came on a wheelchair. And there's an expansion tumor right from the pons up to the medulla and even to the spine. And this, I had all the facilities and explored and debulked to the time when the waves, of course, dropped by more than 50% had to stop. And it was a low-grade glioma. More than 60% or 70% has been removed. And this child is now walking. And this is typical what one of those pictures Manas was showing it. I was remembering that. Total expansion of the brainstem and involving the pons and the medulla. And these have to be evaluated properly. So just to say that, no, I won't touch anything in the pons because it's expansile and on T2 it's showing all white, probably is a little bit of, again, tilting to the other side of the balance. So one has to be very judicious in, now that we have got the DTI, good quality DTI has to be done. DTI doesn't mean that everybody can produce a good quality DTI. It shows a typical expansion of the fibers and there's a lesion sitting on the center. Yes, one should go and it is possible. And of course, with the neurophysiology there, what's the problem?
So Ashish, is not that I don't operate in the brainstem. I routinely operate in the brainstem. I've taken out several tumors. Pons also. Yeah, I've taken out pontine tumors in adults. I've taken out. Like I said, young adults I've taken out. But the question I have for you is that child, I want to know what happened after 6 months. This is what Sandeep has pointed out. Immediate post-op, you have a reasonably good outcome. But what happens after 6 months? Within 12 months, they are dead. That is the problem. Oh, no. And so, it's anecdotally, we can talk about such cases. But when you look at the cohort, and was that H3K27M positive? So these are the issues that I'm talking about. So let us be balanced about it. So I'm not saying one extreme or the other, but these are bad tumors. tumors in the pons in children, centered on the pons. Remember, that's again a very important thing. They should be centered on the pons. So again, like you said, you should evaluate the radiology carefully. Yes, I've been looking at these tumors from 1991 since I've got interested in stereotactic biopsy. So it's a close to 30 years experience. So 30 years I've been looking at these tumors with MRI, initially CT, then of course MRI. We published our initial experience in JNS, Journal of Neurosurgery, way back in 1995. Then we published our bigger experience in stereotactic and functional neurosurgery, where we have given an algorithm for which patients you won't go for open microsurgery and which for stereotactic biopsy. So believe me, these are bad tumors. So please let us not give the message to the younger people that, you should be gung-ho about it. So this should be done with people who have got a lot of experience, maybe like you and Manas,
yes,
but not for the young people. So I would still advise caution when dealing with these children, because whereas you may get away with quite a few, some you will devastate, and even those you get away, in the long term, the ultimate outcome is not going to be good.
Absolutely, well taken. But you have to remember, we are from the days when we neither had DTI, we didn't have MRI also to start with, to be very honest. And now we are gradually improving so much on the imaging. It gives us so much information, number one. Number two, electrophysiology is a good tool now. So there are now things which can help us out. Even if you go in and find anything problematic, you can come out with it. So surgically, yes, we have got some safety parameters to look into. And secondly, if you want a good amount of tissue, as well as relieve any pressure, like, a sort of area with a cystic area or anything like which is compressing, that can be decompressed very well by surgery, and even you can take out some of the material from it. So I think in certain selected cases, I'm not meaning anything where there's diffuse, DTI has been sort of splayed in a different way, or the fibers are going through the tumor. Those are not the ones to be taken up at all. So yes, those are not supposed to be taken. So it has to be selected, judicious sort of selection of cases, which is going to decide which one are the ones to be picked up for surgery, and the rest have to be left for other adjuvant treatment. And as Sandeep said, in small kids, of course, I don't know how good are we in giving chemotherapy in our country. For European countries, it's possible. It's all nationalized service. They have got beautiful sort of system of giving all the treatment. We have no facilities here. Surgery might not cure them. Giving radiotherapy is a big problem for them. So we are still at a loss in certain cases where we don't know what to do.
I always say this is a little bit like climbing the north face of Everest. As time has passed, we have perfect predictions of the weather. We have fantastic armamentarium at our disposal to help us climb those last 2,000 feet, which is the real treacherous part of the north face. But what does not fundamentally alter is the topography of the north face and the unpredictability of the rocks that you have to get a holding on. So, the problem that occurs at a certain point, I find in neurosurgery, is it becomes a challenge between the equipment that we have and our surgical expertise. And there is a molecular stratification and a biological behavior of the tumor that cannot be altered by any form of surgery. And I think that's really what is the critical thing that we are getting to more and more appreciate, as it makes us more and more humble in our efforts to do these difficult tumors. Manas, two last questions because we've very much overshot our time. One is from a young lady from a city called Hyderabad, which you may be familiar with. Her name is Dr. Bhattacharya. I will leave you to guess her first name. She's a young, pretty neurosurgeon from Hyderabad, and her question is, in general, if you have to incise the brainstem, do you incise vertically or horizontally?
It depends. If it's a midbrain, ventrally, vertically, dorsally, horizontally. And if it's a pons, again, ventrally, it is vertically. Dorsally, it is neither horizontal or nor vertical. It's like slanting the suprafacial triangle. And in the medulla, it is vertical. So 70% of time, it's vertical.
Okay, and here's the last question. What sort of intraoperative neuromonitoring do you use when you operate on these brainstem tumors, and how useful?
We just use cranial nerve monitoring. We have not used SSCP or motor evoked potentials.
You do brainstem mapping?
Just mapping of the facial nuclei and the lower canal nerves, that much only. And especially when you're planning on the pons, identifying the facial nucleus has been very useful, because many times it is displaced by the tumor. So it is useful to map the nuclei and then plan the site of entry.
I would suggest.
Do you ever monitor the hypoglossal when you're doing medullary operations?
Yes, yes.
I would suggest you should have the motor evoked potentials. It's very helpful actually. And many times you have a drop and then you can give some hydrocortisone and wait. And once it has happened,
do you have any comment to make before we wind up for the evening?
Sandeep, you're asking me?
I'm saying, do you have any comment to make on brainstem tumors?
I would agree with Dr. Rajsekhar more on the DIPG, because if you have to send a message to the younger generation, then I think we have to be very cautious about DIPG. And the stereotactic biopsies or even open biopsies, I think they're doing it under a protocol as a research protocol for tissue typing. So unless we get more information on that, I think this thing should be very cautious approach to the DIPGs. The rest of the things I would certainly agree with Manas, and very beautiful approach is that he has shown, very elegant. So that focal brainstem tumors would be amenable to excision and so on and so forth. So,
okay. Kaushik, you should have the last word. Any comments on brainstem tumors?
No, not particularly any. Everything has been covered, except that still for a young neurosurgeon like us, it's very difficult to go for an aggressive surgery in spite of whatever tool we have, for the fear of causing morbidity and mortality. And after this WHO classification, especially, and the molecular classification, we are again very skeptical about going full throttle for a aggressive tumor removal. So what is the role of a shunt and a biopsy that previously we used to do in cases of this, especially diffuse tumors?
Which one? Shunt and?
Biopsy.
Shunt
followed by biopsy.
Biopsy and adjuvant therapy, that's what you're saying.
Yeah, so if I can take that, Sandeep, I think the role for biopsy, as Datta has pointed out, is really come down drastically. We used to routinely biopsy in the 90s, but we hardly do it for, I'm talking about the classical DIPG or midline glioma of the pons, classical. So right now, only if the patient has atypical features, either clinical or radiological, then we would suggest a biopsy. Or, like Datta said, you should be part of a protocol where they are doing some molecular studies on the tumor tissue, and then, guiding the patient into some arm of a chemotherapy protocol, then it's worth it. But there is this business of altruism. That means you are trying to benefit somebody in the future, and that has been proposed as an indication for biopsy. That is, you put the child through a biopsy just because you want to benefit somebody in the future. That is something that you have to discuss with the parent, because ultimately you're not going to benefit these children with your biopsy. Most children, at least, let me put it that way. So
I'm sure we will reach a stage where, like we've reached in medulloblastomas, we can use radiology very effectively to predict which sort of molecular subtype we are going to. So we should really aim to get to that in terms of brainstem tumors as well. Yes, Datta, you wanted to make
I just wanted to make, Manas, you had made a report about Professor Nagpal's paper on brainstem. I think he, in his paper, he had mentioned about which, in those days, which cases to really go in, if there are cystic or if there are atypical features, as Professor Rajsekhar said. I think that was a very nice paper in Neurology India, way back in 1980s. And you mentioned that paper, but I just wanted to ask you, do you refer to the same paper, that what I understand?
Yeah, I refer to that paper. That is why, I'm telling you from 1980 onwards, people have been operating. So I'm not sending a wrong message to the young neurosurgeons. Kaushik, I think you should not be afraid of surgery. What I'm telling is 20% of the DIPG probably will be helped by surgery. See, tomorrow, just because we see frontal glioma in the frontal pole, just because it's easy to operate, we should not operate. Tomorrow we'll have a liquid biopsy that we know the diagnosis with the blood only. We don't need to operate frontal glioma. So but then in our experience, the cases which we send for direct adjuvant therapy, they survived less than 1 year. But when you have operated, they have survived 18 to 24 months, and that is rewarding for us. So, and if that 20% people can survive 6 months or 9 months more, probably it's worth it. And I will suggest Kaushik that you should learn to operate rather than think of giving away. And it's not that
you wanted to say something before we wind up.
It's only.
Can I make a point?
Yeah, go on.
Yeah, I routinely do MR perfusion, SPECT, and tractography in patients like this. I mean, sometimes this MR perfusion can give us an idea about the virulence of the lesion, and it's very helpful. I don't know how, whether everybody of you agree with that or not, but that gives me a definite idea that we are dealing with something which is relatively benign and something which is getting out of hands and something which is difficult for the future to sort of deal with. So that gives me an insight, number one. And then of course, the tractography helps me to localize exactly the outlines of the lesion. And that's where I make my decision. And of course, the corridor depends on whether it's coming to the surface or then usually follow the anatomical landmarks, which have already been described very well in the literature, surgical anatomical landmarks. And that's how the lesions are approached.
Thank you very much. I think the north face of Everest will remain the north face of Everest, but we have, in fact, a 16-year-old girl called Bajaj from Delhi who has climbed that north face of Everest. So young people should not be scared of climbing the north face of Everest. We can still get to the summit if you try. So we've had a fantastic discussion today. It just leaves me to say thank you very much, first to Kaushik for organizing this, and then to our two speakers, Professor Mazumdar and Professor Manas Panigrahi, to Professor Ashish Pathak and Professor Raj Shekhar, for very kindly spending so much time on a holiday weekend. But it's been great, and I have to tell you that you all deserve a special thanks, because for the first time you have exceeded all limits of this program, and we could still go on for another hour, for which I have to apologize to Deepak. Sorry for keeping you and extending this program to 2 hours, but I think we could still go on. So thank you very much, and have a very happy Independence Day. And I hope 15th of August will be a turning point to bring down and help us get over this COVID problem that we are all facing. So happy Independence Day, and thank you very much.
Thank you very much, sir. Thank you very much. When the masters come together to say how I do it, the followers come in hordes. In spite of another neurosurgery program going on from AIIMS, we got 341 doctors logging in for this program from 6 different countries, 22 of them from abroad. So thank you very much, sir, Professor Dr. Sandeep Chatterjee, for your insightful questions while coordinating this webinar. Thanks a lot, Professor Dr. Mazumdar, Dr. Manas Panigrahi, for giving your expert guidance on your professional skills, and Dr. Ashish Pathak and Dr. Raj Shekhar for your discussion and your opinion. When masters come, they have the right to their opinion, and they stand on their right because it comes from the experience that they had. Dr. Kaushik Sil, thank you so much for conceptualizing this idea and putting it in practice and bringing the masters together. On behalf of Health and You, I would like to thank the audience, the speakers, the discussion panel members, and Dr. Kaushik Sil and Dr. Sandeep Chatterjee for making this webinar a great success. Thank you very much. Please continue to support Health and You products. This is Deepak Naik signing off on the beautiful backdrop of Shantiniketan, which Dr. Chatterjee has provided, and Dr. Ravi Verma's portrait photograph on the back of Dr. Rajshekhar's beautiful portrait there. Raja Ravi Verma. Thank you very much. On that backdrop, I would like to sign off and wish you a very, very happy Independence Day, and let all get independence from freedom from COVID-19. Thank you so much.
Thank you.
Have a good night.
Good night. Good night. Good night.
Good night. Good night. Good night.